Tonight, I'm going to talk about just basic IVF and infertility and what it takes to get pregnant and why so many people are seeing people like me as a provider. The mission at Kindbody is really to provide the best fertility care to deliver unparalleled patient experience, innovative treatment, and excellent success rates. And, I've worked at Kindbody since March, and I'm really impressed with how I can succeed with the same pregnancy rates that I've had at the other major academic centers that I've worked at in a much calmer, quieter setting. I mean, it's just kind of prettier and more relaxed, but everything that's happening behind the scenes is the same quality. So I feel really happy about that, and I feel proud to be part of Kindbody. What does Kindbody do? Well, primarily we do assessments and treatments. So before COVID, assessments meant coming into the office, but now assessments are most often done as a virtual appointment. So maybe you'll meet the doctor virtually, and I much prefer to meet people in person. So at some point I try to meet you in person before the treatment starts, if you're going to move forward with any kind of treatment. But the main fertility treatments we offer are intrauterine insemination and in vitro fertilization, and they're quite different, and I'll go into it in a little detail. A lot of patients also come for egg freezing, meaning freezing eggs now to use later. People often come to freeze embryos, meaning sometimes you have a hetero couple that isn't married yet or is married, and then both of them are going to law school and they're not seeing having a child for 5 or 10 years. And, all different stories I hear for why somebody would want to freeze embryos and not use them now. We welcome all walks, all patients, all people, doesn't matter gender, like that's not part of the issue. We just try to create family. It's funny, when egg freezing first started in 2004, I remember an article came out in the New Yorker magazine, and they came and interviewed and said, why are you so excited about egg freezing? And one of the comments that one of the other doctors made at a center in New York was, why are women waiting? Like, why aren't they just having children now? And I thought, well, I wish it was that easy. And it's amazing to me where egg freezing has gone from 2003 to now. I mean, it's just exploded. So what does it take to get pregnant? I think probably most people on this call or conference know that it takes an egg from somebody who has ovaries, sperm from someone who produces sperm, a womb. Somebody has to have a womb to put that in. We don't have a womb outside the body yet. My guess is one day they can get it some distance, but the longest that I think embryos have grown in a dish at this point is about 10 days. And we generally do something with them by day 7 after they're out of the body. So from day 1, 2, 3, 4, 5, 6, 7, they do fine in the dish. After that, there's probably more requirements that are coming from the uterus. So what about the egg? So people who have ovaries are born with their eggs. When a fetus is forming in utero, the eggs are made. Like at 20 weeks in gestation, there are 6 million eggs in the ovaries, which is crazy when you think about that. You can't make one egg after you're born, and you make 6 million eggs in 20 weeks in utero, along with all your other organs and parts and limbs. And, it's pretty amazing what goes on in a fetus. And those 6 million eggs, you don't come out with those. You're born and you have about 1 to 2 million eggs left. So why a fetus would make all the energy to make 6 million eggs and then only have 1 to 2 million at birth is still a kind of a shock to me. It must be that it's very hard to make an egg, and a lot of them don't survive. And then you go from birth, where you've got 1 million, 2 million, down to about 300 to 400,000 eggs at puberty. So you're just starting to ovulate. You've got about 450 times you need to ovulate from 13 to 47, 48, whenever you stop ovulating regularly. So you use about 450 eggs and you have 300,000. So lots of extras. But unfortunately, what happens is every single month, and even before you're ovulating, every single month, eggs are dying out. So it's almost like they have a shelf life, and they just die out, die out, die out. And the batch of eggs that dies out, meaning the size of the amount of eggs that are dying out each month, becomes greater, and it becomes greater significantly from age 35 to 40, so that your fertility from 35 to 40 can literally go down by 2/3. And that's kind of a scary thing, because I think back to being 35 and 40, that's as healthy as I've ever been. I had a couple of children already myself, and I was working full time, and I ran the marathon. And, I think about all the things I was doing back then, but meanwhile, my eggs were dying in my body. So I really, even one of the consults I had today, someone was 37 years old, and she said, oh, my insurance is changing in January and I need to wait a couple months after that. And I said, well, when is your 38th birthday? And she goes, oh, next week. So, in my mind, I'm like, wow, you're 38. You're like, to me, that's almost 40. Like, I see that time going by so quickly. And I said, well, a couple of months is okay, but a couple of years is not. So I have to have that conversation with people a lot, because many, many people show up for fertility at 38 when the eggs are already on the decline. Well, how do we evaluate egg health? We use tests we call ovarian reserve. So we either use blood tests, where you can check what's called the follicle stimulating hormone on the second or third day of the menstrual cycle. It's called a baseline blood test. Or you can have an anti-Müllerian hormone, which is a hormone that's secreted by the ovary. It actually is secreted by the follicles where the eggs are. So it gives you a rough idea of how many eggs you have in your ovaries. We also do what's called a transvaginal ultrasound, where a vaginal probe is literally placed in the vagina, and that's very close to where the ovaries live in the body. And we can see the number of antral follicles, little follicles ready to go inside the ovary. And together, this information is really helpful. When I look at FSH and AMH on the slide, I realized for like 25 years, all I used was a baseline FSH, because the AMH test wasn't that great in the beginning. When it first came out, it was kind of all over the map. But now it's pretty tight, and it gives you a broad stroke. It's not a perfect test, but it gives you a broad stroke for how the ovaries are doing. And it's what I use. I hardly ever use an FSH anymore. So I've really transitioned to the anti-Müllerian hormone as my assessor of how the ovaries are doing. This is a picture of what that ultrasound looks like. So the probe is sitting at the top of the vagina. This ovary with the little black circles in there, that sort of almond-shaped structure you see on the slide, is actually the ovary, and those little black circles are the antral follicles. So some people have 1, 2, or 3 of those. Some people have 50 of those when we put the probe in, and we go, 50. Oh, you have a lot. Or 2, that's not so good. But most times people have 6 to 12 antral follicles when we look in a given month. What does that egg have to do? Well, the egg is released from the ovary, that sort of pinkish white structure at the bottom of the slide, and it releases most times into the fallopian tube, which again is kind of a miracle. When you think about this little fallopian tube sitting there, and it's got a vacuum on all the time, it's kind of like suction's kind of always on, because the egg gets released, it pops out of the egg kind of randomly, and then the fallopian tube picks it up. It's really kind of miraculous. And the egg is then in the fallopian tube, and the sperm gets up into the uterus and into the fallopian tube. It literally the sperm swims into the fallopian tube and meets the egg at the far end of the fallopian tube most of the time, fertilizes there, and then these little hairs that line the inside of that fallopian tube take that embryo back to the uterus over the course of like 4 days. It's like going on a hiking trip for 4 days, and reaches the uterus and then implants in the uterus. And the kinds of things that go wrong here are maybe the fallopian tube's not so great. Maybe you had an infection before. Maybe you have endometriosis and there's inflammation in the fallopian tube. Maybe it's blocked altogether. I mean, we used to see a lot of blocked tubes in the 80s when there was a big prevalence of undiagnosed chlamydia. When I was a resident, I saw it all the time. And when you have tubes that don't work so well and the created embryo doesn't travel well, you get what's called an ectopic pregnancy, where the embryo can actually stick to the wall of the uterus and start growing there. But again, that's gone way down since the incidence of chlamydia, like undiagnosed, like long not treated chlamydia, doesn't exist so much anymore. Well, why do we worry about aging? As I said, the eggs are dying out every month, and 35 is sort of that age where you go, things are starting to change. So until about age 35, for most women, if you haven't had chemotherapy, if you haven't had a lot of surgery, if you don't have a family history of early menopause, things like that, things that are outliers, usually you do pretty well at 35. Like when women come to me at 35, I say, you know what, gods are really good that you're going to get pregnant one way or another. But as a woman ages, things get harder. Like the egg quality isn't as good. Maybe if someone has fibroids in the uterus, they're growing, there can be confounding factors that make things harder. So I usually am pretty relaxed until 35, and then I really turn it up. And at 38, I really turn it up. I can basically say, it's your choice, but if it were me, I would get moving. It's important to know that we look at both egg quantity and quality, and you can't really measure egg quality outside the body. You can't look at someone and go, oh, she's got nice skin, she's probably got good eggs. There's no like marker, you know, like your ear shape or your hair color, your hair length, or none of that tells you what your eggs look like. You can work out every day of the week in the gym, and that doesn't tell you anything about your egg quality. So the main way we see egg quality is when we have it in the dish and we put it with sperm and see what happens. Like, does it fertilize well? More important, once it's fertilized, does it develop well? So in fact, the egg runs on the woman's sort of reserve when it's sitting in the dish. So the first 3 days of what happens in the dish comes from the woman. It's almost like it charged it up and said, okay, go, pushes it out the door and says, go. And it works till about the 3rd day. And then on the 3rd day, the embryo has to take over and do the work. And so that's where we start saying, okay, people usually fertilizes, usually develops a couple of days. And then we see from day 3 to day 5, starting to peter out. Okay, not such a good egg. So that's one of the ways we see a quality issue. And the other is if you get the embryo out and you see it grow 5 days, and even if it grows beautifully, you can take some of the cells and check them and see if the embryo has a normal complement of chromosomes, meaning the right number of chromosomes. As far as in the body, how do you test quality? Well, the litmus test is getting pregnant on your own, right? Like having sex or getting sperm put into your body somehow, and then seeing if a good embryo develops and continues to develop once it implants. Well, what's the biggest issue with age? If you look at this slide, the yellow bars, this is by age, so percent by age, the yellow bars are the live birth rate when doing treatment. And you see from 35, 37, looks pretty good, and then it starts dropping off. So the drop off in live birth rate is at about 38. When you look at the aneuploidy rate in embryos, meaning when we take embryos out of the body and we test them, you look at what percent of embryos are abnormal. So at 35, I generally tell people it's about 50-50. This says 30% are aneuploid, but in general, what we see when we test them is that they're about 50-50. Or maybe I don't see 2 out of 3 normal. Actually, I think that number is a little too high on the slide. But when you get up into the 41 age group, what we see 40 and 41, what we see is about 1 in 10 embryos are normal. So that's kind of scary when you see that at the clinical level. And I'm, in the lab and I get the result back and I say, whoa, she's got 10 beautiful embryos here and 1 is normal. Whoa. And again, because I've seen it so much, that's why I get scared at 38, 39, 40. What are the things that can go wrong for ovulation, like releasing that egg out of the ovary? Well, some women, generally in layman's term, make a little bit too much hormone. So polycystic ovary disease is where literally polycystic means there's a lot of cysts in the ovary. So those antral follicles, instead of seeing 6 or 12, you see 20 or 30. And because of that, you see more hormone in the body, and that can just mess up the concert where you're trying to have this, concerted effort to have the egg develop, mature, release, and then get fertilized and go to the uterus. Other things that can affect ovulation are sometimes people have thyroid disorders, has to be like a real thyroid disease, not like subclinical thyroid, like a real thyroid disease. Some people have a pituitary tumor. I've only seen it about, I don't know, in my whole career, 30 years, I've seen about 20 times where they have a real prolactin problem, like a prolactin level that's 50 to 200 and causing ovulation problems. But it does happen, and we do check that if the ovulation's off. Some women don't release enough hormone from their hypothalamus, meaning there are organs in your brain that control your ovulation. So things come out of the hypothalamus and drive the pituitary, and then the pituitary drives the ovary. And if you don't make enough hormone in the brain, it doesn't tell the ovary what to do and the egg doesn't come out. And that can be because you're genetically born that way. That can be because you exercise too much. So in New York, I have seen way more than 10 women. I've seen probably, thinking back, I'm just doing this really freehand, but thinking back, I've probably seen 300 women in 30 years that don't ovulate correctly because they exercise too much. So there's a lot of women in New York that are sort of type A hard drivers, go to the gym 1.5 to 2 hours every day. And sometimes that's too much. If you have no body fat and you're not eating enough, your body thinks you're starving. And it says, forget it. I'm not going to ovulate. I need this energy for other things. Some women have primary insufficiency, but I usually only see that if there's a genetic history, like say the mother had a menopause at age 30, or the patient has had chemotherapy or a lot of surgery or something that's actually damaged the ovaries. What can be wrong with the fallopian tubes and the uterus? I talked a little bit about the fallopian tubes getting damaged either by inflammation, say endometriosis, or some old infection, a chlamydia infection, gonorrhea infection. I mean, I don't see that too much anymore either, but I saw a lot of it in my residency. And in the uterus, there are lots of things that can go wrong. So on the picture that's on your left, the uterus is, I don't know if I, oh yeah, I have a pointer. There's the uterus sitting in there. This is the bowel, right? This is the bladder where you pee from. And then this is the bowel, the uterus, and then this is the bowel. So it kind of sits in there like a little sandwich. So sperm either gets up there with a catheter, or you have sex in the vagina and swims up out the fallopian tube and then comes back and implants in this uterus. Okay. So what's going on during the cycle? Well, you have a follicle grow. So one follicle gets picked from the ovary. How out of 300,000 one gets picked? I have no idea. I have no idea. I don't know if it's a random selection or if there's like survival of the fittest and the best egg comes out. We don't really know how the one egg gets picked, but every month in most women or most people that have ovaries, one egg gets picked and matures and ovulates. So as that happens, this is the maturing follicle, we can actually measure this follicle. So those are the black circles we see when we do ultrasound. We see the size of the circle, and it usually gets to about 20 millimeters. I don't know if you know what that is, 2 centimeters at the time it's going to ovulate. And then it pops out. And all this time, it's making hormones. So one of the primary hormones it's making is estrogen. And what that does is go to the uterus and gets it to develop. So we see the uterus lining thickening up too. And so it's really a concert. It's pretty amazing that the egg is developing, it's making estrogen, the estrogen's going to the uterus, making the endometrium develop, egg pops out, and that follicle that was making estrogen flips to a progesterone factory. Miracle, right? We should sell this. No, miracle that you can go from estrogen factory, progesterone factory. And then progesterone is the main support hormone of pregnancy. And that happens every month you ovulate, from 13 to 47, 50, whenever you stop ovulating. I'm not going to go into the tubes much more. I talked to you about that twice already. This is looking at the endometrial lining that we look at the time you're ovulating. So if you think about the uterus as an apple, it's kind of shaped more like a pear, but say it's like an apple and you cut the apple down the middle and you're looking at the seeds. This is the middle of the apple, and here's the seeds of the apple. And that's actually where you implant. That's the cavity of the uterus. And it literally gets this thick. We measured this thickness. And this little line here is literally like the front and back wall coming together like this. And usually we like to see that somewhere between 6 and 10 millimeters at the time of ovulation. No, I did that already. Oh, am I going backwards? I think I'm going backwards. Sorry about that. Yeah, I was. Sorry. Evaluating the uterus, there's a couple of things we do. Either we put water into the uterus, say in the office, we can literally feed a catheter into that cervix, into the endometrial cavity, and put some water. It's literally saline that we put in there. Or we can have you go and have an x-ray at a radiologist's office, and they put dye in there and take a picture with x-ray. And the kinds of things we're looking for are little fibroids or polyps. Like that's a fibroid, that's a polyp, that's a fibroid. I mean, you can't tell the difference, but I can tell just even from the picture. And so this is a big lesion. It's a big polyp that's sitting inside the uterus cavity. It shouldn't be. It should just be a black space, right? Water is black on an ultrasound. So there should be a black space, but instead there's this big lesion in there. So it's a very useful test to see what's going on inside the uterus. Other things I've seen, and I actually fixed 2 of these in the last month, is a divider can form in the middle of the uterus. And this forms when you're in utero. So at 20 weeks in utero, when you're making all those eggs, you're also making your uterus. And it starts as 2 balls on the side, and it comes together in the middle like this. And then the middle resorbs. And sometimes that middle doesn't resorb perfectly, resorb perfectly, sorry. And you can have what's called a septum, like a little stick sitting down the middle that's not very vascular and it's hard for an embryo to implant. Or you can have a deeper thing where even the outside is dipped and you have like a double cavity. So we can see this when we do the saline sonogram, because we have 3D potential when we're doing that. Sperm can also be an issue. Almost half the cases of infertility are due to, if you take away age of the woman, about half the cases of fertility are due to sperm. And it's not really due to the shape. This is showing you all kinds of funny shapes, but it's really much more due to the concentration of sperm and the motility of sperm, meaning how much they're swimming. On average, men have more than 15 million sperm per cc of semen, and they have more than 40% motility of the sperm that's there. So 15 million, 40% motility are kind of what we're looking at as the bottom numbers. And the way they came up with those numbers, the WHO looks at this about every 15 years. So literally the World Health Organization looks at this and they say, okay, people trying to get pregnant, try for a year, get pregnant, don't get pregnant. What do the sperm look like? So the lowest concentration of sperm that gets people pregnant in 1 year of trying with intercourse is how they set that lower number. So sometimes I'm looking at analyses and I'm doing an insemination or a semen analysis evaluation, and I see, oh, it's 10 million or it's 5 million sperm instead of 15 million. I say, this is probably contributing to the problem just based on those WHO numbers. There's a panel of female testing that we do. If we are going to do fertility treatment, there's a test of things we do. We want you to have a pap smear within the last 3 to 5 years, depending on where you are in your age and what pap smears you've had before. We want you to have a physical exam. We want you to have a breast exam. We usually check hormones, thyroid and prolactin are those two, the thyroid gland in the neck and the pituitary gland in the head. We look for infectious disease screening, hepatitis, HIV, syphilis, gonorrhea. There's a panel of tests that people want done for preconception. So it's a sort of standard preconception panel. And then there's a genetic carrier test, which I'll talk to you about on the next slide, which looks at whether you're a carrier of diseases. So things like Tay-Sachs, cystic fibrosis, sickle cell disease. There's literally 500 diseases now they can check for, which is kind of crazy. But there is. We check to make sure you're immune, like you've had the right vaccines that are given in the United States, rubella, measles, varicella. And if you're not immune, we usually recommend that you have vaccination. So we usually put off getting pregnant to get you your vaccination. So for the genetic carrier screening, if 2 people are each carriers, 2 people coming together who want to be carriers, even if it's donor sperm that you're buying in a bank, if each, the donor and the intended mother or the couple, the 2 people that are trying to have children, each carry the same gene, that's 50% the child will be a carrier, 25% the child will be affected, 25% it won't be affected. So most people who we test and find have the same genetic disorder, like cystic fibrosis is 1 in 22 Caucasians. So I've seen that. I've definitely seen couples come in where they both carry that gene. And then we can test the embryo for it before we put it back in, before we create the life. We can screen out the ones that are affected with the disease. So the important thing when, considering going to a fertility doctor is, what am I looking to do? It's like, I remember when I was walking up to medical school, I had taken a year off and skied all year. It was a really good year skiing. And I was walking up the hill going, what am I doing? Why do I want to be a doctor? I like skiing more, but I actually love being a doctor. But I just remember walking up that hill and I feel like I walked back out 10 years later. I don't even remember those 10 years of my life because it was a lot of work. But, thinking about your goals, like my goal was I wanted to be a doctor. Like that was it. I was positive I wanted to be a doctor, at least when I applied. And then once I got started, had a little window there. I was like, maybe I'll be a ski bum. But thinking about your goals do you want to get pregnant now? Do you want to get pregnant later? Do you have the money, the means, the partner, the sperm source, whatever it is? Do you have that to get pregnant? Most of the times women are freezing. It's either because, or people with eggs are freezing, is because they aren't in a position, in a relationship conducive to childbearing, or they're on some astronomic path in their job. Like either they're just lost their job and they need to get another job. That's a lot of things that happen in the pandemic, a lot of shifting around, or they're on this steady path, like maybe making partner in a law firm or something like that, which is so intense. Like I even said for myself, once I was at the other end of my medical training, when I was at the end of fellowship, I was like, oh, there's no way I could have had a baby in that training. It was just so hard, all of it, and so much responsibility. And literally, I delivered my daughter the day I finished fellowship. It's kind of crazy. I went and did my last day of fellowship and I delivered that night. So that was kind of crazy. So a lot of women are coming and saying, I'm not ready now. I want to preserve my fertility. And other people are saying, no, I'm really trying to get pregnant now. And so we really tailor the treatment to that. The other piece is like, what is the long-term goal? Like, are you looking to have 3 or 2, or not many people say they want 5 anymore, but people usually either say, I want 1, 2, or 3 if they're coming in to have a child. Or some people who are freezing say, I don't know if I want any, but I want to maintain my option to have a child. And that's very reasonable too. You could be 28 years old and say, I don't know what I want to do. I don't know. I mean, literally, some days I wake up and I don't know what I want to do. It's like, I don't know. Do I want to go out to dinner? I don't know what I want to do, So people are not sure a lot of the times, but they don't want to give up the option. And I think that's really important to know that you have the option to freeze the eggs at the age you are now to be used at a later time. I would say the most major issue I've seen in fertility over the years, the 2 biggest things I've seen are women waiting a little too long, like showing up at 38, 39, 40, or 41. And that's gotten a little better. It used to be 41, 42, 43 in the 90s and early 2000s. And now it's like 37, 38, 39. So it's come down a few years, but a lot of women still come too close to 40. And the other issue is polycystic ovary, where the concert isn't just right, where there's a little too much hormone. So things aren't just working just right. Those are the 2 major issues I've seen over the years. I mean, I've taken care of all the other things, but those are the 2 biggest ones I've seen. I already talked about banking eggs or embryos. It's really whatever's right for you. And you have to realize that this is pretty new. I mean, the first freezing I did was 2004, and I've frozen thousands of women's eggs at this time. But even in the beginning, the first couple of years, 100 women, 200 women. Then all of a sudden, like 2013, 14, it was like, 300 women, 400 women. It really picked up in the that second decade of the 2000s. And now I see it feels pretty almost like routine. It's like, okay, if I'm not ready to have a child, if I'm not graduating from college and going to have a child right away, maybe I should consider something with my fertility. And I'm really grateful for that, because I just don't want anyone to miss it. These are just stats on being infertile, trying for 1 year. 1/8 of couples experience infertility, and 1/3 of those are male factors. So that's just some basic facts. So I'm going to talk a little bit about in vitro fertilization. As I said, in general, every month your body recruits as someone with eggs, the body recruits a set of eggs in the ovaries to start growing and maturing, and then one will ovulate naturally. And when we give you fertility medication, which is FSH, follicle stimulating hormone, that's what those fertility medications are that you take for IVF. They are exactly what your brain puts out. So your brain, the area of your pituitary, puts out follicle stimulating hormone. Of course, it develops follicles, right? That's why it's called follicle stimulating hormone. And if we give you more of what your body sees naturally, it just makes more eggs produce. So we give the medication, the FSH, for about 10 days-ish, sometimes up to 2 weeks, for about 10 days. And it causes a batch of eggs to mature instead of just one. And then we take those out of the body and put them in a dish. So, I didn't know the movie was there. Sorry, I didn't know that movie would come. And they do teach you, sorry, I didn't know that movie was there. There is a movie that teaches you how to take the medications. And there is a weekly medical teaching session where they can show you how to do the medications as well. But we take the eggs out of the body. It takes about 10 minutes. It actually takes me 5 minutes to do an egg retrieval. You get sedation. During the procedure, we use a needle. It goes through the top of the vagina where the eggs are located. So literally the ovaries sit right at the top of the vagina. If you took that skin away at the top of your vagina, your ovaries are sitting right there. And so we can advance a needle right into the ovary, just like when a doctor puts an IV or a nurse puts an IV into your arm and they can see that vein and they go into the vein. Same thing. We go into the ovary and aspirate out the fluid that's around the egg, and the egg pops off when the fluid is gone. On average, we get somewhere around 5 to 15 eggs, sometimes more, sometimes less. And sometimes we use the AMH or the antifollicle count test that you had with the sonogram to predict how many eggs you'll have. But I honestly don't really tell patients how many eggs I think they'll get, because I don't really know. Even all these years, whenever I come out of the OR, I say to the nurses, what do you think? What do you think I got? What do you think I got? Literally yesterday, I did 7 retrievals. What do you think? And they guessed right some of the time, and they guessed wrong some of the time. So we never really know how many eggs we're going to get at a given time, but it's usually an adequate number. After the eggs are taken out of the body, they're placed with sperm in a dish and literally put in an incubator, kind of like making a cake, maybe, I don't know, whatever you make in the oven. And you put it into an incubator, which isn't as hot as an oven. It's body temperature and it has special nutritional value in the fluid in the dish. And we literally just leave those embryos to develop. We don't bother them. They just sit in there and develop on their own. And after 5 days, we take them out and look at them and we see how many have gone to the blastocyst stage. So we want an embryo to be a blastocyst when we put it back into the uterus. And we can see, and about 50 to 60% of fertilized eggs go on to be blastocysts. That's a blastocyst on the picture. So if you look, they call it a blastocyst because this is a cystic area. See, this looks like water here. These cells are what we call the trophectoderm, and they actually have already differentiated into the cells that will become the placenta. And these cells in here, believe it or not, that's you and me sitting in there. These cells are what become the baby. So it's called the inner cell mass, and these are called the trophectoderm. Baby, placenta. That's already happened. By the 5th day, it's already decided, I'm going to be a placenta, I'm going to be a baby, which is kind of amazing when you think about it, that the differentiation occurs in 5 days for a human being. So we look at all different things to see what makes an embryo healthy. How does the blastocyst look? Does it have nice cells? Like this has really nice cells. You can't tell that, but I can see all these cells look like they're about the same size. This trophectoderm isn't my favorite. I would give it a B. I mean, the cells kind of, when they're an A, it kind of looks like a nice ring, like someone's bought you jewelry. This one's a B, but good enough. You can test the embryos. So there's a way to test the embryos. And this is like a little catheter that's holding the embryo in place with a little bit of suction. And you can actually take a couple of these cells, like just take these 2 cells out, say, and you can test for chromosomes, which is kind of crazy when you think about it. That's so cool that you can take 2 or 3 cells out of an embryo, not even touch the baby part, and still take those cells. And about 90% of the time, you can tell if the embryo is chromosomally normal or not. It's crazy, honestly. The reason we do testing is we're trying to increase the chance of implantation and reduce the chance of miscarriage. Unlike a lot of people, I mean, it's kind of 2 schools of thought. Some people say, oh, PGT everything, just PGT everything and always put a normal embryo back. But actually, when you look at the data for many, many years, we didn't do any testing. I mean, it started around 1990, but it didn't really take off until about 2010, 2015. And so there are many years we put untested embryos back. And still as my primary sort of go-to recipe is if someone's under 38 years old, I often will put the best looking, like the beauty contest embryo back in. So I'll put 1 embryo back into the uterus because then it doesn't have to go through the biopsy, the freezing, the thawing. The woman doesn't have to wait, 4 more weeks to get an embryo put in. And then depending on the age, I will either test some of the embryos or not test the embryos. It really depends on the age and what the couple wants. So the reason I test at least a couple of them is because if you don't get pregnant with that first transfer, I know how people's brains work. They're like, oh, what did I do? Because IVF is like, you line up for IVF, you want that to work. You know what I mean? Like if I'm at the top of the scale, I want to get down in one piece. So you line up, you want it to work. It doesn't work. It's like falling off a cliff. And you say, okay, I don't care what it's going to take. I want to get a baby the next time. So at least that second time, if you're putting in a euploid or a normal chromosome embryo, you got a little, push or incentive that yes, it's going to take. Honestly, the pregnancy rate is not better if you're under 36 and you put a euploid tested versus a pretty blastocyst back in. It just because so many of the embryos are normal when you're younger. But I tend to biopsy a couple of them, not all of them. Like you could have 10 embryos and I might only test 4 just to know if you want a tested embryo after the fact, like say you fail or you succeed and you're 35 and the next time you're having a baby is 37 or 38 and you go, okay, now I'm scared. Do I have a normal embryo or not? That's why I do a couple of them. And I put a lot of thought into that. That wasn't a plan. I just said, oh, maybe I'll do this. No, I put a lot of thought into that as my go-to. Who does PGT benefit other than older women? If you've had a lot of miscarriages, if you've had failed IVFs, if you have a family history of genetic disease, like some people know they have genetic diseases that you want to screen out, like even the BRCA gene, the breast cancer gene. A lot of women who find out they have breast cancer gene actually come in and screen embryos for the BRCA gene. maybe someone has a genetic disease it can be just one person that has it, that creates it. There's specific diseases like Huntington's chorea. There's specific ones where only one person has to have it to pass it on. Hemophilia is one of those. Older woman. I don't know about older man. I haven't generally recommended it for older men. Benefits of PGT is the results. You can know the sex of the fetus. It may increase the risk of success, and you don't have to do more invasive testing. But quite frankly, with the way testing goes in pregnancy now, you can have something called a non-invasive pregnancy test. It's a blood test they can do. So literally at like 9 weeks of pregnancy, there's already fetal cells circulating around your blood. And they've figured out a way to sift out those fetal cells in your blood cells and test them for chromosomes, which again is kind of a miracle. It didn't exist when I was a resident. Kind of a miracle that someone said, oh, let's find the fetal cells in the maternal bloodstream and then let's test them for chromosomes. It's kind of like a pipe dream in the beginning, but it's like, oh, wow, it works. So it works I think it's about 75% accurate. That's what I would say. It's not 100%. I've definitely had people get results back that are abnormal when their child came out normal, and have had people be told it's normal and that it's abnormal. So it's not 100%, but it's 75%. And that, along with looking at the fetus and how it looks anatomically, like in the uterus, in the sonogram, gives you about probably more than a 90% chance that you're not going to have an abnormal baby, because most abnormals actually abort by about 12 weeks of pregnancy. Reasons not to do PGT: it requires more stuff. You have to do more to the embryo. You have to take some cells out. You have to freeze the embryo. It costs money. It's just more, and more isn't always better. So just setting expectations with fertility. If you're doing in vitro fertilization, say we see 12 follicles on the sonogram, we might get 10 eggs that about 70% fertilized. So you might end up with 7 embryos of 10 mature eggs that are, the first day fertilized. Then about half of those go on to the blastocyst stage. So now you're down to 2 to 4 embryos. And then if you test those, you might end up with a normal, you might not end up with a normal. It kind of just depends how many you have. It's a little bit of an odds game. But I generally tell patients, I've been saying this for more than 10 years, about 15 years, 10 eggs generally gives you about 2 great working embryos. And that just sets expectations. So it's not every follicle that comes out, every egg that comes out is a baby. It's about 10 eggs gives you about 2. And if you're lucky, 4 good embryos. Embryo transfer. Would you have a fresh embryo transfer or frozen embryo transfer? Many people have moved to frozen embryo transfer, and that's with or without testing. Part of that is because you get what we call hyperstimulated when we take your eggs out. So we get your ovaries really revved up and you feel kind of bloated and you can retain some water. And if you get pregnant on top of that, it continues that sort of water accumulation. You feel kind of crummy for another 3-4 weeks. And so in the old days, literally in the 90s, we always put embryos back in because frozen embryo transfer wasn't very good. And so a lot of women would get hyperstimulated in those old days. We'd be like, no pain, no gain, you'll be fine. And they would get better. Rarely did we admit anyone to the hospital. But if you are very stimulated, like say, if someone makes 18 eggs or more, I generally don't put a fresh embryo back in. I usually wait, let the body calm down, and then put an embryo in. And if you have the PGT testing, the testing of the embryos, it has to be frozen. It goes back in another month. And on average, about 98% of embryos will survive the thawing process. So it doesn't like ruin the embryo to freeze and thaw it. Transfer. What happens with transfer? We use a very thin, it's like a cooked spaghetti catheter. Literally, it's like flexible and it's narrower. It's more like angel hair than like a thick pasta. And we feed that, the embryo is in the syringe that's attached to that. We feed that flexible catheter into the uterus. No anesthesia or anything. We often do it under ultrasound, but no anesthesia. And we feed that into the uterus and then just gently inject the embryo with a little bit of fluid into the uterus and let the embryo stick. So it's really up to your body and much more the embryo, whether it's going to stick or not. And usually it does so about 2 days after the embryo transfer. And we see a positive pregnancy test about 9 days after the transfer. Chances of pregnancy. I think it's important for people to know, if you look at people who are 35 and under, if you're doing intrauterine insemination, say with letrozole or Clomid, the chance of pregnancy in a given month after trying for a year, if you tried for a year and you did not get pregnant with intercourse or some means of getting sperm into the body, then the chance of pregnancy working with, say, a letrozole or Clomid intrauterine insemination or timed intercourse cycle is about 10 to 15%. It just is. Even a normal fertile couple that is trying to get pregnant, it's about 20% per month. So if you're 25 years old, getting married, hetero marriage, going to have sex for a year, chance of getting pregnant each month is about 20%. But if nothing's wrong, it generally goes 20, 40, 60, 80, 100. And after 5 months, most people who don't have any problems and aren't old will get pregnant. So if 5 months go by and you're young and you're having regular relations or sperm's getting into the uterus and you're not getting pregnant, something's probably off. Either you're a little bit older and your egg's harder, the sperm's not so great, the tube's not so great, you might have fibroids, blah, blah. And that's why we do a whole workup for infertility if you come in and you've been trying and you haven't gotten pregnant. If you do in vitro fertilization at 35, depending on where you look at the stat, like from the retrieval, from the transfer, PGT, blah, blah, it's about 40 to 50% chance of a live birth. And if you do PGT, it's about 50%. So it's basically the same whether you do PGT or not with that first transfer. There is cumulative pregnancy data. So in the United States, it's about 300,000 IVF cycles done a year. So you're not alone if you're doing IVF. Literally 300,000 cycles occur just in the US alone. And when you look at cumulative pregnancy rates, if you say the first cycle from retrieval on is about 40%, the second cycle would get you up to about 60%, and the third cycle gets you to about 72%. So that's cumulative. It's not like the third cycle is 72%. It's cumulatively with the 3 cycles. And if you're 41, it's 19%, 31%, and 35%. So the problem is the older you are, the harder it is to get pregnant. So it's really risky to wait into the 40s to say, okay, I'm going to start a family now, which is what I saw so much in the 90s and the first decade of the 2000s. I guess I just want to end by saying the path to parenthood isn't linear. I mean, I see all different things happen, and some women get pregnant in a month, and other women, like I called a woman today who had to have PGTM. She had to test for a specific disease in her embryos, and her first transfer didn't work, but guess what? Today it did. So I called her and it was like, here, you made it. You made it. Right before the holidays, you made it. So it changes all the time. And we have a lot of support. If you need support, we have people who can support you. It's called Kindbody 360. I guess at the end, there's no magic formula and everyone is different. As I said, I feel very experienced as a fertility provider. Again, I've been around about 30,000 IVF cycles. I've done more than 10,000 egg retrievals myself. I've done a lot of surgery over the years. Although I don't do surgery anymore, I stopped this last year because I'm just too tired to do surgery, honestly. It's been a long career, but I know what surgeries people need. I just don't want to do them anymore. Kindbody's kind of everywhere. It's amazing. I feel like they're growing every week. I hear we have a new clinic opening. It's really unbelievable what's going on. It's really special. This all started since 2018. So Kindbody is on a mission to be your fertility provider, which is really kind of a cool thing. And that's really all I have to say. I know I talked 78 speed, and I hope I answered some questions, and I'm happy to answer more. Thank you.
Thank you, Dr. Noyes. That was amazing. Does anyone have any questions? If you have any, please feel free to drop them in the chat so we can get Dr. Noyes to answer them.
Oh, how do I stop share? Let's see. There we go. No questions?
Oh, we're starting to get some now. Someone said, yeah, we're getting them in now. Okay. Is there any medication that you know would affect fertility?
Oh, that you mean to make people less fertile? Chemotherapy really is the main one. I mean, there are certain medications that you can't take while you're pregnant. Those are called teratogens, where they can actually have a teratogenic or a body altering effect on the fetus. So there are certain medications that are classified as teratogens, and they don't want you to take them in pregnancy. But other than chemotherapy or radiation therapy, where you really get blasted to the ovaries, there aren't a lot of things that affect fertility. There aren't a lot of medications that say make you less fertile. In a man, I will say in a man, if men take testosterone shots, which some men do, and they don't realize that can affect fertility, that can actually shut off their sperm production. I've only seen that 3 times in my career where the man hasn't told his partner that he's taking testosterone shots and he refused to have semen analysis, and they come in to do their fertility treatment and there's no sperm there. Only 3 times. That's not bad in 30 years, but it's, that's a one-offy thing. Otherwise, no.
Thank you, Dr. Noyes. Another question we have here is, do the eggs degrade as a function of time that they are frozen?
No, that's a very good question, actually. A+ for you. We were worried about that, actually, not so much with eggs, but with embryos. We're like, geez, is it like your food in the freezer? Like when I was a resident, I always had such an erratic schedule. I'd look in my refrigerator and be like, I think I bought that a long time ago. I don't know. I better not eat that. Like food in the refrigerator goes bad, they say, in like 4 days, right? But eggs and embryos are in liquid nitrogen, which is minus 300 degrees. So it's like static. As soon as it hits that liquid nitrogen, it's static. It just shuts it off like a glacier. And so embryos have been thawed 30 years later and used and created birth. 30 years in the freezer, can you imagine? And sperm as well. I think sperm, the longest, it's somewhere around 28 to 33 years. I can't remember which one it is, but somewhere right around that same time. And I've personally used eggs 14 years later. So negligible breakdown because of the temperature being so low. It's like a flash freeze, and then that's in the freezer, minus 300 degrees.
Great, thank you. We have another question here. Is there a risk of the IVF extraction procedure?
Yes. Funny you say that. Somebody yesterday had a bleeding disorder. I did 7 retrievals yesterday, and someone said, "Oh yeah, I have Willebrand's disease." I go, "Really? That's really risky." So some people have diseases that make them higher risk for bleeding, and that's pretty scary for doing the egg retrieval. Sometimes they have to take medication before to decrease the risk of bleeding. But in general, the main risk is bleeding, but we do it very carefully under ultrasound. I've had 2 bleeds in my whole career, literally, in over 10,000 retrievals, where somebody got a blood transfusion but didn't end up with surgery or anything. But I have had 2 patients get blood transfusions over the years. That's really low when you think about tens of thousands of procedures. But so you can cause bleeding, but usually not. And the other big risk is infection, but I haven't seen an infection in a really long time, years and years. And we used to see much more in the 90s when there was much more undiagnosed chlamydia around. So it's kind of sad that in the beginning of chlamydia, when it was in the United States in the early and mid 80s is when it really took off. And there wasn't a great test for it, and people weren't very forthcoming who had it. So there was a lot of undiagnosed chlamydia, or say somebody would find out they had chlamydia, but they wouldn't tell their sexual partner. I mean, it was just kind of nuts, honestly, when I think back. And women would have these horrible tubo-ovarian abscesses from it, but we don't really see that anymore. I mean, people are more, even if they just ghost you and say I have chlamydia, like people will tell each other they have a disease, or they don't think it's a big deal to tell you, and people go get treated. So I haven't seen a lot of undiagnosed chlamydia, not even a handful in my professional career. Have I seen people come in where they didn't know they had chlamydia and they actually did? Really rare now, so I'm happy about that. So infection and bleeding is the short answer to the question.
Thank you. And we have another question here. When you say surgery affects your ability to get pregnant, I assume you mean uterine surgery of some sort?
And no, sometimes, sorry.
It says not like foot surgery, haha. And does that affect the number of eggs, or I assume the ability of eggs to implant?
That's funny you say that. I don't think foot surgery. I can't think of anything in the foot. Gout, right, is what people get in the feet, or like diabetes, right? No, I don't think either one. The surgeries that affect fertility the most, honestly, one is for what we call endometriosis, which is a spontaneous disease that some women get where they make scar tissue in the pelvis. It's from the blood that usually comes out the cervix at the time of the period, going out the fallopian tubes instead, retrograde bleeding out your fallopian tubes. And that blood is inflammatory to the pelvis and causes scar tissue. And so when you start, operating with that, or there is endometriosis there, that can lower the chance of pregnancy. And the other big one is when women have giant fibroids and you have to take out, like I've taken out 40 fibroids in one woman, and you just have holes all over the uterus when you finish. There's defects from all those fibroids and you have to sew them up. And so there can be scar tissue there. And if you have to do something in the uterus, like say someone has a baby delivery, and the placenta doesn't come out. So sometimes that happens where you pass the baby, but the placenta just decides, I'm not coming out. And it can stay stuck in there for a little while. And the doctor has to go back in and do what's called a D&C and scrape it out. And then it's still not done. And they have to scrape it out again. Like I've seen that when I was a resident, where the placenta was just really stubborn and wouldn't come out. And that can scar the uterus lining. So those are the primary things you see, is either bad endometriosis, lots of fibroids, or where you have to operate inside the uterus and there's inflammation there too.
Thank you. Another question we have here is, what is live birth probability for eggs that were frozen using the slow freezing method?
That's funny that someone's asking that. I want to know who that is. You better text me. No. So when I first was doing egg freezing, we didn't know whether slow freezing or vitrification was better. We really didn't. I mean, it was the beginning, and I was going over to Italy 5 times a year, which wasn't bad. Believe me, the food is really good. And it was easy to travel before COVID. So I went over a lot, and I got a lot of experience from them, because they had an issue where they weren't allowed to fertilize more than 3 eggs. They weren't allowed to make extra embryos. It was a Catholic thing across the country. And even now, they're not allowed to throw out any embryos. So they have a lot of Catholic restrictions in Italy. So I used to go over a lot. And they were doing slow freezing in the beginning. So I learned how to slow freeze, and I learned how to do it really well. So at my job that I had for a long time, we were doing slow freezing in the beginning. And then over time, we switched to something called vitrification, which is the flash freezing or the faster freezing. One takes about 10 minutes and one takes about 2.5 hours. So it really moved to vitrification because it's faster, honestly, and you don't have to rely on a machine. So when you do slow freezing, you have to use this, it's called a cryoplaner, or this thing that takes the temperature down a degree a second. You hear it clicking, click, 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 click. You'd hear it in the lab clicking away as we were freezing the eggs. And somebody has to stay there 2.5 hours to make sure the machine doesn't break down, or that it finishes the cycle, or nothing goes wrong, because you can't just hope that the bread's going to be okay in the morning. And so it takes longer. And you have to rely on a machine. And sometimes those machines would break down. You have to get another machine. It got a little hairy. And when you're doing a lot of cases, even though vitrification is a little trickier to do, it's so much faster that it's almost better to learn the tricky, if you could wash your clothes in 7 minutes, or it takes 2 hours, which one would you do, right? You're going to do the 7 minutes or 10 minutes. So everybody has pretty much moved to vitrification around the world. But when I was first doing it, even for about 5 years, I would do half slow freezing, half vitrification, because I didn't know which one was better. And quite frankly, we published that data, and we have the exact same pregnancy rate with slow freezing and vitrification. So one wasn't better in our hands. When you look at the live birth rate from frozen eggs, if you go to a good program, it's about 1 in 3 women, average age 38, 1 in 3 women get a live birth. And that's from thousands of cycles that I did at my prior job. I hope that's helpful.
Thank you, Dr. Noyes. And we'll take one last question here. Does Kindbody have an age limit for intended parents who are using a surrogate?
Does Kindbody have an upper age for intended parents using a surrogate? I don't know the answer. I mean, I'm sure they do, but I don't know what it is. I haven't done a lot of surrogacy over the years because New York State had a law that prohibited payment of surrogates. So until 2021, February 2021, in New York State, we could not do surrogacy for payment. So the only surrogates I ever did were sisters or best friends growing up, or cousins or sister-in-laws. I probably did 25 of those over the years, where it was an altruistic carrier. So we could do people who are willing to carry for free. All they could do is pay the medical bills for the pregnancy. But now, since 2021, we can do paid carriers. So it's become, a little bit of a business in New York. I don't know the answer to the age, but I'm sure someone at Kindbody could tell you that. I don't know the answer. Sorry.
Thank you, Dr. Noyes. And I'll just follow that up by saying, if you contact our patient navigators by emailing navigator@kindbody.com, they'll be able to answer that question for you. So thank you all for joining us tonight. We really appreciate it. We hope you learned a lot from this session. If you have any other questions, you can always contact us at navigator@kindbody.com or reach out to us via social media. We're on Instagram at Kindbody and Facebook as well. Have a great evening, everyone. Thank you all for joining.